right, good evening, everybody. Welcome to our presentation, Achieve More with a Healthy Pelvic Floor. Both Kathie and I are super excited to educate you a little bit on the pelvic floor.
All right. Hi, everyone. I'm Kathie Olson. I am the program director at the Center for Incontinence and Pelvic Health. I have about 30 plus years of experience. I have a master's degree from the University of Cincinnati, and I'm a certified pelvic health nurse practitioner. Well, not pelvic health, but women's health nurse practitioner with, like I said, lots of experience.
And my name is Natalia. I received my bachelor's from University of Scranton in 2017. I then continued on to my doctorate of physical therapy, which I received in 2020. I knew I wanted to do pelvic health as soon as I was in PT school, so I went full force into it. I got my pelvic rehab practitioner certification in 2021, and most recently just received my pregnancy and postpartum corrective exercise specialist.
So our goal tonight is to have a discussion with all of you regarding pelvic health and pelvic pain. We're going to talk about anatomy, those possible causes for pain, why to see a healthcare professional, because it's very important to seek help because there are many options, and what are the different treatment options for pain. I always tell women all the time, it's not in your head. If you're feeling something, you need to actually get that evaluated and talk with a healthcare professional about it. So when we talk about pain is, why do you have the pain? So one of the things I forgot to say on my introduction is I always tell people that I am the detective. And both Natalia and I, our jobs, or when you come in to see us, is one, to figure out what's going on. So whether the pain is with, it may be with intimacy or with sex, it may be, you may notice discomfort when washing or when standing, when moving your bowels or passing your urine. When we talk about that, it's very important to investigate the causes. And it's often the best method of treatment is a multidisciplinary approach using your healthcare providers, including it may be your primary care physician, your gynecologist, somebody from our department at the Center for Incontinence and Pelvic Health, someone like Natalia, a pelvic health physical therapist. And so that we all work together to come up with the best plan for you. So the first thing, it's always very important. I think that one of the things we need to do is become educated so that we can be empowered to make decisions about our health. So one of the first important things is to understand our anatomy. So let's talk a little bit both about female and male anatomy. So like I said, it's understanding those parts and getting a better understanding. I don't know, Natalia, do you have a pointer that you can use to point out the spots? I know it's on there. It's just hard to
I don't know if
sometimes.
I've ever used a pointer on. Is my mouse okay? Can everyone see?
Yes, I'm seeing the
Yes, you
mouse.
can see the mouse.
Okay.
That works.
Okay, cool.
So it's very because most women don't know their parts. And so first we need to talk about, if we start up near the abdomen, you have your mons, and in that area, you'll notice there's usually more hair distribution there, but as we get older, there is less. But sometimes you can have folliculitis and irritation in that area. Below that is the clitoris. Again, we can have pain in that area. There can be changes in the clitoris as we age. You then have the vestibule. So that's that tissue kind of below the clitoris, but surrounding those other areas. You have the urethra, and the urethra is where the tube where the urine exits the body. And then below that is the vagina, all right? And then if we go a little bit further down, it's the perineal body. It's the area between the vagina and the anus, all right? You have your labia. You have what's called the inner labia or the labia minora, and then you have your labia majora. And it is amazing that those areas, when women come in with pain, our job is to identify, when we talk about more of that superficial and not a muscular pain, is to identifying that source and where is the pain actually in that area.
Doesn't want to switch. Okay, there we go. So I'm going to dive a little bit deeper into the pelvic floor muscular anatomy. So your pelvic floor muscles aren't visible to the eye, so you might be unaware of their existence, but they serve a very important purpose. There are 3 layers to the pelvic floor muscles. I'm going to grab my little model here for everybody to see. So in the front, we have our hip bones and our pubic bone. In the back, we have our lower spine, our sacrum, and our tailbone back here. So if we take a look at this picture over here, we can see the pelvic floor muscles are going to sling back to front and side to side. So from that pubic bone towards the tailbone, almost like a hammock, to support the internal organs. So whether it be the bladder, the uterus, the rectum, and then also the prostate for males. There are 5 functions to the pelvic floor. I like to call them the 5 S's of the pelvic floor. So they're going to support those internal organs. They're going to have a sphincteric function to open or to close, to maintain continence, or to allow you to go to the bathroom. There is a sexual function for these muscles. They're going to work directly with your core or your abdominal tissue to help stabilize the body. And then your pelvic floor and your breathing muscle or your diaphragm are actually going to work together like a sump pump for lymphatic flow. So I want everyone to do a little experiment to see if they can find their pelvic floor muscles. So if you take your hand and you slide it underneath your butt and find your sit bones, your fingertips are actually going to be pointing up towards the pelvic floor muscles. So I'll give you a second to get situated. And one of the main first things that I always teach my clients is breathing and how to coordinate your breathing with your pelvic floor. This is really important before we get into anything else pelvic health wise. So with your fingertips right underneath your sit bones, I want you to take a big breath in, and I want you to see if you can feel anything kind of sinking into your fingertips. And then when you exhale, see if you can feel those muscles kind of lifting up and away from your fingertips. If you felt that, that's great. If not, maybe you need pelvic PT. All right. And then we're going to jump into a little bit of male anatomy. So there are some similarities for male anatomy, but there's also some differences. So a male bony pelvis is actually taller and a little bit more narrow than females. They're going to have one additional muscle suspending from the abdominal tissue towards the testicles. They have 2 openings instead of 3 for females. And they're going to have very similar functions as the female pelvic floor does. This is one of our male pelvic health models. I'm a visual learner, so I like to incorporate these in my sessions with clients so that you really can grasp and understand the area of the body that we're going to be working with. This is just another detailed chart for your reference on male anatomy specifically.
So when we talk about our team, it's really important that you get, like I said in the beginning, evaluated by a healthcare provider, whether it be a MD or a physician, a nurse practitioner, a physician assistant. And the idea there is to really rule out, identify, and treat any medical causes for your pain. In addition, when you come to the center, we do that initial beginning working you with your pelvic health, your pelvic muscles. Again, I didn't say this, but I always joke with Natalia that I'm the Cliff Notes to pelvic floor physical therapy. Because I've been around for a long time, fortunately or unfortunately, I have been working and instructing with Kegels or pelvic muscle exercises, but it is more of a brief education where Natalia will go into much more detail.
Yep, and then just to jump off of Kathie, I'm going to specifically evaluate and treat the structures related to pelvic floor anatomy. So this is going to include the pelvic floor itself, all of those muscles, but it's important that we look at everything holistically. So we're going to look at your posture, your breathing, your lumbar spine, your sacrum, and your lower extremities as well.
So what happens next? When you talk about coming in, I have women come in every day and say, you know, I wish I would have come in sooner, because they're always anxious or worried about what's going to happen at this visit. And so when you come in to see someone at a facility to talk about your pelvic health, a couple of things are going to happen. At the Center for Incontinence and Pelvic Health, what's really nice about that initial visit is we do spend an hour, because we do want to educate you on, again, talking about your anatomy, what's going on with you, to get a history. We do an exam. If we need to do any additional testing, we can do that. And based on that, we put all of those pieces together to come up with a plan. When we talk about your history, yes, we look at your past medical history, the medications that you're on. It may be deliveries, it may be other issues. Like Natalia said, as you were looking at that model that she had, yes, your back, your hips, they all play a role in all of this. So it's very important that we get that detailed history. We're going to look at medication. We're going to look at how your bowels are functioning, how your bladder is functioning, how your vagina is functioning. It was interesting. A patient came in to see me today, and she actually got referred for a bladder issue. But when she came in, it was really her sexual function that was an issue, but she didn't know kind of who to ask or where to go to. So to me, that's why it's very important that we talk about all those areas. And the other thing, as you saw with the model that Natalia showed you, is that all those areas actually are interrelated. They can affect each other dramatically.
Mm-hmm. Yeah, and just to go off of that, Kathie, it's very true. And it's oftentimes when we're screening all of these different systems, a patient might come in thinking that they have a urinary issue or a bowel issue. But then when we start going through their history and we get a detailed idea of their habits and their patterns, we often find that there's actually dysfunction in other systems as well. So it's important that both of us take that holistic approach and look at all of these systems.
So when you come in to see us, everybody always says, do I really need an exam? And I always say, how can I determine what's going on if we don't do an exam? But first thing you're always going to do is always check your urine, because it is amazing. We want to look for, make sure there's no blood in the urine or any infection or anything like that that's going on. We're going to look at that external tissue, just like when we were looking at that diagram. We're going to look at all of those areas to make sure that there's no redness, there's no infection, anything like that that is going on. We do an internal vaginal exam, because now, depending, if you come in and you've had pain with intimacy and that an exam is painful, we may not do an exam with a speculum. We may not even do it with a digit or with a finger. But the idea is that is our goal, to be able to evaluate that. We want to look at the tissue to see if there's changes. We're going to look to see if there's any relaxation of the vaginal walls or that the uterus is dropping down. Can you find your pelvic muscle? Is your pelvic muscle tone too high? Most of the women, every woman comes in and says, oh yes, I've learned those Kegel exercises. And I will tell you that in 30 years of experience, maybe 10 people have actually been able to engage those muscles properly. If you're coming in with bowel issues, we will do a rectal exam. And depending on what we find with that exam, we may do swabs to actually look for a yeast infection, a bacterial infection, another type of infection in the vagina, and also to rule out any other diseases that could be going on. So when we do all of that, like I said in the beginning, our job is to, one, be the detective. So we need to come up with maybe even a diagnosis or some differential diagnosis, those different things that may be going on. But the other thing is to educate you. Part of what's very important, just like Natalia and I talked about at the beginning, is that when you come in for a visit, we're going to do that education. And then we're going to come up with a plan together so that you can have control of how we move forward. It's very important if we can find to rule out any medical causes of pain. And sometimes it can be a combination of both medical causes and pelvic floor issues. One of the problems too is if you've had pain for a long time, or urinary frequency for a long time, or constipation, all of those things can affect your pelvic muscles and what's going on there. So it's really important that we address things from all sides. So when we talk about some of the changes that can occur to the vulvar tissue or to the urethra and things like that, you can have some inflammation. Sometimes it is amazing that there are contact irritants that can cause discomfort. So one of the things I want to warn all of you about, and you can please share it with your friends, family, daughters, is always pads. That is one of the things that we find is a contact irritant for many individuals. So wearing them for your menses or your period, or wearing them for urinary leakage can really cause irritation. Things such as soaps, detergents, all of that. So sometimes just reducing those, we look at those reversible things, things that are very easily removed from our everyday life to make things better. We want to do things that are treatable. We want to address if you're having urinary leakage or frequency to go to the bathroom or constipation. We want to make sure that we treat that, and that sometimes inflammation, when we talk about a lack of estrogen, and we're going to talk about that a little bit later, that is something that inflammation from that lack of estrogen can actually cause incontinence or be a component of that. And then we want to look at that vulvar tissue to make sure that there are no chronic issues, such as something as lichen sclerosis, lichen planus. And those are things where women have itching of the vulvar area, can come and go, but it actually needs to be treated. There are infections such as sexually transmitted infections that can actually cause urinary frequency, can cause pain. The other thing, I was just having a conversation with one of the physicians that I work with, that you can have a yeast infection that can be causing pain. You might not have the discharge. Everybody thinks of that white, nice cottage cheese itching that occurs with a yeast infection, but sometimes you can actually have pain with sex that is actually caused by a yeast infection. The other thing is that there are different types of yeast infections, so we want to make sure that we rule that out. And you can have a bacterial infection that can be causing that discomfort or pain with sex. Changes in estrogen. Natalia and I were talking at the beginning of this that, people really underestimate that those changes in estrogen can be such a dramatic cause, or changing that environment can make a huge difference in our comfort with intimacy. We think about changes in estrogen with menopause, but the other thing you want to understand is that women that are on birth control, because of the changes that it causes in the levels of estrogen, can actually cause pain with sex.
And also, to piggyback off of this too, I see a lot of postpartum moms that are breastfeeding.
Absolutely.
When you're breastfeeding, your prolactin levels are really high, which is going to deplete your estrogen. And there's just a lot of hormonal changes that happen postpartum as well. So this is another phase in life where we might see that estrogen deprivation, and we might need a period of like a topical estrogen suppository prescribed from a physician.
I also want to tell women too that there's no, I think people think that lubrication or moisturizers are just meant for the older postmenopausal women. But honestly, as our cycles change, our hormonal levels change, that lubrication also can vary. And so sometimes the things we talk about, such as moisturizers and lubricants, they're very appropriate for younger people. We just don't talk about it enough. But genitourinary syndrome of menopause happens after menopause, when we're no longer, and it can happen, these symptoms can begin perimenopausally. And so you want to do the pointer again, Natalia?
Oh, yeah.
So if you're looking at the slide, and on the left, you see this nice red tissue that has little ridges in it. It's very elastic. The vaginal wall has a lot of support. The arteries, you have good blood flow to the area, and those folds are called rugae. You can see the length of the vagina. It's actually, compared to the right, it's actually longer. It actually has more depth higher up, closer to where the cervix and uterus is. And so that's what our vagina looks like when we're younger. It's nice and pink and healthy. What happens with menopause is your vagina can get a little shorter. It gets thinning of the vaginal walls because of that lack of estrogen, and because of that, also reduced blood flow to the vagina. Because it's not as elastic, it also doesn't produce as much lubrication. Because of atrophy of the outside tissue, or that lack of estrogen, that vagina actually externally can reduce. And sometimes actually the urethra and the tissue at the opening of the vagina can begin to recede in. You can also get narrowing at the opening of the vagina. And so it's really important when we talk about genitourinary syndrome of menopause that we address it. Does this mean that every woman needs estrogen vaginally? No, not necessarily, but it can make a big difference. However, there are things such as moisturizers that have been shown to really make a big difference, and to make sure that we're using a good lubricant. And if we don't talk about it now, I'll make sure at the end I'll keep you all in suspense and give you some names of some really good moisturizers and lubricants. So there's something that I want to touch base on, not that we're going to spend a lot of time on it, but it's called painful bladder syndrome. And one of the issues is, I had a patient come in today that her pain with intimacy is all related to her bladder. It is her bladder. It's not her pelvic muscles that are painful. So painful bladder syndrome can be frequency, urgency, pain with your bladder filling, pain with emptying. It can also be pain with intimacy. And so when individuals come in to see us, we want to rule this out. It is, I've had patients that go online and think it's a chronic, it is chronic, it is not curable. However, we can make it much better. With a combination of treatments in the office and pelvic floor physical therapy, we can really make some significant changes. One last thing, and Natalia is going to talk about this a little bit more, but it's prolapse. This can begin to occur after childbirth. It is more of an issue even with it's hereditary, but it's also related to childbirth and kind of how we go through the delivery process. The issue with prolapse is it can be very minimal, or it can be extending out past the opening. Many women, when they call the office, they think they have a tumor, something's at the opening of the vagina. And so when we talk about this prolapse, it is a vaginal prolapse. It's the walls of the vagina or the uterus, and we can address this. And Natalia is going to talk a little bit more about it, and then we can talk about at the end some other options.
Mm-hmm. All right, so what is pelvic floor physical therapy? I'm biased, but I think it is the best kind of physical therapy and the most important. But it is a conservative, non-surgical approach for the muscles that support bowel health, bladder health, and sexual health. The type of therapy prescribed is going to depend upon the symptoms you're experiencing. So some people will require relaxation and lengthening of the muscles, while others may require strengthening of the muscles. It's very important that your care is individualized because everybody is going to present differently. Therefore, we need to tailor the modalities specifically towards you. And like Kathie was saying before, pelvic health is not just about Kegels. A lot of people don't understand how to do Kegels properly, or it might not even be indicated for their symptoms and the condition that they're coming in for therapy for. So there's different things that we can do in pelvic floor physical therapy, which I'll run through briefly. So we could do different behavioral modifications, like talking about toileting habits, your water intake, your diet. I have clients do diaries all the time. So food logs, bladder logs, bowel diaries. Diaries tell us a story, and it can be a really important kind of cue into what may be causing some of your symptoms. We can do manual techniques such as internal or external releases, focusing at the pelvic floor or towards the back, the hips, the gluteal area. We can use different modalities such as heat or ice, electrical stimulation, kinesiotaping, as well as biofeedback. Biofeedback is a great machine that we have here, which I typically like to use for constipation if there's any incoordination going on. It's also really great to get in touch with your pelvic floor muscles and to see what's happening with your pelvic floor muscles in real time on a computer screen. But it is really important that prior to doing biofeedback, you're getting your pelvic floor assessed by a physical therapist, OT or PT, pelvic health specialist, to understand what that muscle integrity is like. Because you can still have weakness of your pelvic floor if your pelvic floor is tight. So we want to make sure that we're taking the right approach before doing that assessment. We can also use biofeedback with things such as like a mirror. So you can look how your pelvic floor muscles are moving and functioning. And then any type of cueing, verbal cueing, tactile cueing, all of that are different forms of biofeedback. We could do different types of exercises like pelvic floor contractions or Kegels, core strengthening, hip strengthening, and then stretching and mobility is also extremely important. And then in pelvic PT, we do a lot of education. It's really important that you understand how we're going to be approaching pelvic PT, the area of the body that we're going to be working with, the anatomy of the pelvic floor, all to help you take that active role in your healing. Then we'll also do functional retraining and functional movement patterns such as squats and hip hinges and things like that. But it's really important that we understand the tasks that you want to get back to in your daily life specifically. I always encourage, if I'm seeing postpartum moms, to bring their babies in, because what's more functional than lifting the weight that you're actually going to be lifting throughout the day? If there's any specific exercises or sports that you're looking to get back to, we always incorporate that into therapy as well. So at your first visit for pelvic PT, we get a 60-minute evaluation one-on-one with your therapist. We take a very thorough look at your past medical history and your current symptoms. We do a lot of education, like I said previously, on the anatomy of your muscles, joints, nerves, organs, connective tissue, everything that may play a role in your symptoms. Then we'll take a look at your posture, your breathing, how your back is moving, how your hips are moving, the integrity of your sacrum, the nerves, your strength, and then we can palpate the muscles of the back, the pelvis, the hips, the abdomen, and the pelvic floor. We want to look if there's any scar tissue in the pelvic floor, on the legs, or in the abdominal area. We take a look at how that scar tissue is moving. Specifically with maybe a C-section scar, we want to see if there's any swelling, any redness, any hyper or hyposensitivity. I see a lot of moms that have the shelving or the cliffing of their cesarean incision. So we'll work on scar mobilizations to break that up as well. And then if indicated, we'll do an internal pelvic floor examination, either vaginally or rectally, based on your comfort level. Our exams are going to look a little bit different than what Kathie does. She's really making sure that, again, is there anything medical going on? I'm looking more specifically at the muscles themselves. So there can be many misconceptions about what a pelvic floor assessment consists of. So in pelvic PT, we don't use any tools or speculums in our internal assessments, just one gloved finger. And I think this differs a little bit from Kathie. You use a speculum?
It depends.
Okay.
I mean, it depends on the patient, kind of what's going on. Not every patient has a speculum exam. They've just had their gynecologist exam. I may not need to do that.
Okay.
And we are looking at almost the same types of things.
Yep. So the exam, like I said, can be performed vaginally or rectally based on your symptoms and how you're presenting, and we'll use our clinical judgment to kind of determine what's the best course of action. A pelvic floor assessment is going to give us really important information on how to guide your plan of care moving forward. So like what Kathie said before, it really shows us exactly what's going on, what's causing the issues, and what we can do to help you. So for example, we want to figure out if your pelvic floor muscles are tight or are they weak. And what the range of motion of your pelvic floor muscles are. So someone with a tight pelvic floor can still have urinary leakage, and someone who has leakage may think that they have to strengthen the pelvic floor with Kegels. However, if we give a tight pelvic floor more strengthening before we stretch the tissue, it will continue to make the leakage or the pain worse. So I want to do a quick example. So if everybody holds their hand out with their palm open, and then you can close your hand into a fist. Think of that as your full range of motion of your pelvic floor. So full relaxation and a full contraction. Now squeeze your hand into a tight fist. And then if I asked you to make a tight fist from here, there's really not much more range of motion that your muscles can get in your hand. So the same thing can happen in your pelvic floor. And we can still get weakness because your muscles are stuck at the end of their range of motion here. Again, leading to weakness. So continuing to pump your fist muscles or to strengthen your pelvic floor in this shortened range of motion is only going to tire out those muscles and make the symptoms worse. So that's why Kegels aren't necessarily for everybody. And I always make sure with my patients, even if we are taking the strengthening route, that everybody knows how to fully relax and get that full range of motion in between each contraction.
And I want to support that with Natalia, with the years of experience. And because when I started, there weren't pelvic floor physical therapists. So I've been trained to do a lot of these things. And And one of the things is everybody wants to do these exercises and tries to quickly get them done. I'm going to do that squeezing. And I'm like, but you
Yeah.
need to relax. It
Mhm.
is very important. And I agree so much with what she's saying, that taking that time to not only tighten those muscles if appropriate, but really relaxing. And so many, Natalia, we both know that so many of our patients, especially when we talk about pain, are really talking more about relaxing the pelvic floor.
Yep, yep, exactly. So with our pelvic floor assessment, as long as the client is comfortable proceeding with this part of the examination, we're going to start by looking at the muscles externally. So we're just going to start by visually looking at how those muscles are moving. So we'll ask you to bear down like you're having a bowel movement, and then we'll ask you to do a pelvic floor contraction or a Kegel. And we want to see how much that tissue is actually moving. And then from a pelvic floor contraction, how long does it take for you to relax or get back to that resting tone? We're going to look at your involuntary muscle movement, either through coughing or laughing, to see if those reflexes are intact. This is especially important for people that may be experiencing leakage with coughing, laughing, sneezing, jumping, like those quick things like that. We want to make sure that that reflex is intact. And if it's not, then we'll educate you further how to incorporate that and rebuild those reflexes. We're going to look at any scarring and then also the skin integrity externally. And if I'm noticing anything that might indicate an infection or something that might need to be treated with either topical medication or any form of antibiotic, then we would send them back to the appropriate medical provider. Kathie, you can prescribe medications like that that would help if they are presenting with anything like that. And then we can move on to the internal portion of the pelvic floor examination. So we're going to look for prolapse or any downward descent of the pelvic floor organs into the pelvic floor muscles. We can palpate the muscles superficially and deeper. So like I said before, there's 3 layers to the pelvic floor muscles. We assess and palpate those muscles at each layer of the pelvic floor to see if we can determine, is there a specific muscle or specific side of the pelvic floor that may be causing your symptoms? We're also going to look at your coordination of each layer of the pelvic floor, specifically with your breathing. So earlier in our presentation, I had you see if you could feel your pelvic floor muscles and see what happens when you are breathing. I take a lot of time to educate my clients on that and help them to understand how to be using their pelvic floor with their breathing, especially during functional exercises to prevent pain or leakage. Then we're also going to examine the strength of your pelvic floor. So how much are you able to squeeze? What does that feel like? And how long you can hold that contraction for. This slide here goes over some conditions that we treat in pelvic floor PT. This isn't an extensive list. There's a lot that we can see in pelvic PT. Today, we're specifically going to touch on dyspareunia or painful sex, constipation, prolapse, and postpartum issues. So the first condition, dyspareunia or painful intercourse, is a common sexual dysfunction. There was a study published in 2019 stating that 8 to 21% of women experience recurrent genital pain before, during, or after vaginal penetration. These conditions can occur from injury during vaginal delivery, pelvic inflammatory disease, infections, adhesions, abuse, and other psychological factors like anxiety and depression sometimes. And because of this multifactorial etiology, it is important that we get that multidisciplinary approach like Kathie touched on earlier in the presentation. The musculoskeletal system plays a huge factor in this pain. So modifying the tone of the pelvic floor is an effective way to treat this dysfunction. So think of like if your hamstring got tight or you have a knot in your neck, the same thing can happen to the pelvic floor. And just because those muscles sit internally does not make them any less important to get treated than pain elsewhere in your body.
Natalia,
So,
can I
yeah.
just interject? So one of
Mhm.
the things I want to say too is that when this pain starts, one of the problems is as women, we kind of grin and bear it and
Mhm.
we don't seek treatment. And honestly, we're doing ourselves a huge disservice when we do that. Because if you're having pain, and then what happens is your muscles think, oh, I'm going to protect you. I'm going to tighten all up when you go to have intimacy. And then what happens is it actually, the pain gets worse and worse. And so it's really important, the sooner that you reach out to a healthcare professional regarding this pain with intimacy, the sooner we can, and it will heal much quicker if we can address it
Mhm.
sooner. Sorry, I
Yeah.
just had a,
No, I completely second that. It's very true. I talk about that with my patients all of the time, how important it is to build those positive experiences with intimacy or any type of penetration. And we always thank you for being brave to disclose that to your healthcare providers because there is a solution out there for pain in the pelvic floor. So during pelvic PT for dyspareunia or other types of pelvic pain, we can perform various manual techniques like myofascial release, intravaginal massage, trigger point releases to the muscles internally at the pelvic floor, externally at the pelvic floor. And then again, we're taking that holistic approach and we're looking at muscles of the lower extremities, your hips, your glutes, your lower back, and your breathing as well. Manual techniques and breathing can improve the awareness of your pelvic floor, which is a huge first step in treating any pelvic pain condition, is having that awareness of your breathing and that control over your pelvic floor. And then again, we can release those tender spots to normalize the overall tone of the pelvic floor. The next topic that we'll talk about is constipation. Kathie and I did a presentation on this about a month ago, and I could probably talk about constipation for 2 hours. So this is a very brief, abbreviated slide on constipation and pelvic PT. So constipation is a condition in which a person has uncomfortable or infrequent bowel movements. Generally, you're considered constipated when your bowel movement results in passage of small amounts of hard, dry stool, usually fewer than 3 times per week. It is really important to take a look at your trends and your patterns. So that's where those diaries are going to come into play because maybe I only go to the bathroom 3 times per week, but someone else goes 3 times per day. As long as I've always gone 3 times per week, then that would be considered my normal. But if I was going more frequently and then all of a sudden it shifted one way or another, then we would be concerned. So we'll talk about things like the squatty potty. So elevating your knees higher than your hips helps to relax the pelvic floor muscle and make it easier to have a bowel movement. We can adjust water intake. We can make dietary changes such as fiber. And we can also get you on a good bowel schedule to help increase habituation for the colon. Previously, I discussed biofeedback for dysenergic defecation. So dysenergic defecation is an in-coordination issue of your muscles of the pelvic floor and the core when we're having a bowel movement. So that biofeedback machine can really help you to see what's happening in real time to your pelvic floor muscles. I even do this during my examinations or treatments with one gloved finger, being able to give that feedback to my patients as they're practicing those defecation mechanics. We want to get to the root cause of the issue. So a lot of times people are prescribed laxatives or stool softeners, but oftentimes the issue is actually a muscular issue itself, either with the pelvic floor or the core. And those laxatives and medications aren't getting to the root cause of the issue. We can also do things like abdominal manual therapy and regular physical activity to help increase colonic transit time. Anything you want to add, Kathie?
so I had to run out because my daughter came in and she was very excited. So I missed a
Ah,
little bit. But all I want to really say, I agree. I do the same thing as Natalia does when you come in. And it is amazing how many people don't know how to poop. Like the appropriate process, we take it for granted. And so many people have had constipation or bowel issues since they were kids. And so the whole process of of defecation, we think it, like I said, should be easy, but positioning,
Mhm.
relaxing your pelvic muscles and breathing. And a squatty potty, I just want to tell all of you, I don't know your ages, but I'm a little older. And I used to tell people to put their feet on phone books before the squatty potty was around. And I would have been a millionaire if I would have not seen patients and just invented a squatty potty. But I will tell you, it is the best thing. Give it out as Christmas gifts this year.
Mhm.
Every house should have at least one squatty potty, because all of those things make a difference. And that's what's really great of what, when patients come in to see me, I can do this initial assessment, kind of some of the similar things as Natalia, but she really has that experience with some of those other those other muscles. Your hips are really tight. It may really affect how
Mhm.
you're sitting on the toilet and how those muscles are relaxing. So
Yeah.
we can make a huge difference with simple stuff. I mean, I'm sure Natalia and I could both tell you stories of patients who have been given many
Mhm.
medications, Linzess, all of these things for their bowels. And we just do some simple muscle changes, positioning, breathing, and their bowels
Mhm.
begin to work so much better. Not all the
Yeah.
time, but it can be amazing.
Yeah, absolutely. I do want to backtrack real quick because I realized I forgot to touch on the dilators and pelvic wands for pelvic pain, which are some of my favorite tools. So I can't believe I left that out. But dilators and pelvic wands are great for pelvic pain, for down training those tight muscles or that pain that we're having with penetration. It's not always the first line of treatment based on the patient's comfort level. But there are so many people out there using tools like this, and they find them extremely helpful. So if you've seen like a Theracane that you might use for your neck, this purple wand up here is kind of the same thing for your pelvic floor muscles. And we can use it either vaginally or rectally, depending where your symptoms are. Same with the dilators. These are vaginal dilators right here. The rectal dilators are a little bit different in shape, but they are great tools, and I thoroughly go over how to use these to help, and we can use them during your home exercise program. So sometimes people need a little bit more attention internally to their pelvic floor muscles, and this is a great way to do that at home when you're not in therapy.
And the other thing I'd like to add with the dilators, and I'm sure Nat and Talia, you'll agree, is one of the things that happens with the dilators, we talked in the beginning about that anxiety about anything going into
Mhm.
the vagina because of the pain that you've had. And then those muscles begin to contract. And what's really nice with dilators, it gives you the control when something's going in the vagina. And it actually really helps your brain understand that, oh, something can go in the vagina without any pain.
Mhm.
And, and people look at these. I mean, most of my patients, when I do the dilators, I don't even have them open the box until they come in because they look at them and they're afraid of them. And we really just start very slowly. And it can really, again, make that difference in your brain and your vagina and your pelvic muscles relaxing.
Yep. Yeah. So you want to move slowly through the dilators. There's some people that we take a couple of sessions, so once a week or one session once a week to go over just one dilator, and we might do that for 3 or 4 sessions. So my rule of thumb when I send people home with these to practice this is do not progress the dilator if you have more than 3 out of 10 pain or 3 out of 10 anxiety towards progressing that dilator with penetration. Another really cool thing is I always invite my clients to bring their partners in if they feel comfortable. Their partner can learn to use the dilator, and sometimes allowing your partner to practice the dilators with you can just build those positive pain-free experiences with penetration. And I kind of find it breaks down that wall to be able to educate the partner into what's going on can be really, really helpful in a lot of cases. And then again, if we're seeing any signs of anxiety or depression or trauma, we will always refer out to other like-minded providers that are there to support you in that holistic, multidisciplinary way. All right, so moving on to prolapse. Kathie touched on this briefly before, and if you have anything to say, just feel free to jump in. So like any muscle in the body, they can be stretched, strained, or torn. And when that happens, the organs that the pelvic floor supports can slip out of place. So this can happen with time. Muscles can become weaker over time. During pregnancy and delivery, there's extra strain on your pelvic floor muscles. And then menopause, hormonal changes, things like that can all change how those organs are sitting in your body. So it's important to go over breathing and pressure management. Again, we go back to that coordination of your breathing, your diaphragm with your pelvic floor muscles. We're going to go over posture, strengthening exercises, behavioral techniques. So a lot of times patients will say they can't fully empty their bladder, or maybe they try to pee and then when they go to stand up, they have a little bit of more dribbling or they get a second urge to go. We can talk about splinting or other behavioral techniques to make it a little bit more comfortable to go to the bathroom to have a bowel movement. We always want to look at constipation with a prolapse. We want to avoid any type of straining or intense bearing down that might increase that pressure down onto the pelvic floor. Proper water intake and then going over a good voiding schedule is all going to help with this. And then we can talk about pessary management in conjunction with pelvic therapy if we feel like that prolapse is a little bit progressed. And as we're starting to work on strengthening the muscles, a pessary can be a really great tool to add into that.
So let me just interject. So a pessary, they come in all different shapes and sizes. But usually when we're talking about younger patients or even my older patients, the idea would be to try to use a pessary that you could independently take in and out. And they kind of, if you've ever used a diaphragm, they kind of look like a diaphragm, but they're round and sometimes we can just use one that's round in a ring, but a lot of times there's a platform on it and they fold like a taco shell and can go in the vagina and they support everything. What's really nice about that is if you're having a lot of pressure or discomfort, the pessary can resolve it. But here's what I always like to tell women. If a pessary works for you, you don't know that it's there. And it is a great way to utilize this and at the same time begin to work with physical therapy to strengthen your pelvic muscles, because now this bulge that's kind of pushing down on the muscles is out of the way and you can begin to strengthen those. But there are different types of pessaries. And if the prolapse is significant enough that's bothering and all of these things don't work out, there are wonderful surgeries now that can actually treat these conditions.
Yep. There's a common misconception that we also can't exercise or lift weights or lift our children or anything like that with a prolapse. And again, once we learn how to manage our pressure and breathe properly and do proper pelvic floor strengthening exercises, core exercises, hip exercises, none of that is true. You can lift, you can get back to what you enjoy doing, you can exercise without those feelings of pressure or heaviness. And you can also learn to modify things to make that a little bit more comfortable for yourself.
I want to just interject to him that I had a patient this week that came in who had prolapse. I had seen her like 6 months ago. She did a little pelvic floor physical therapy, but then she really got back to the gym when she was feeling comfortable on how to lift and how to do things. And her prolapse is not even bothersome at this point. With doing those exercise strengthening those other muscles, your core, your hips, your thighs, I was amazed at how much more how comfortable she was, how much of a less of a prolapse there was. And I know that English was not very good right there, but so I really want to support what Natalia's saying there, that sometimes all of those things we think we need to avoid because we have the prolapse, actually doing those will actually make things better. But like Natalia said, using the right techniques and maybe sometimes modifying what exercise regimen you're doing can make a big difference.
Yeah. It's amazing how many women come in and I'll ask them to squat down and show me how you would pick something up off the floor at home. And they're actually bearing down and kind of holding their breath and putting so much pressure down on their pelvic floor. And sometimes even within a couple of sessions, just going over the breathing and body mechanics and things like that makes a huge difference. And it's really important that you can do that and get back to doing the things that you love. because we don't need to be restricted by pelvic pain or prolapse and other pelvic floor dysfunctions. It is important to note that with pelvic PT, it does take time. It takes at least 6 to 8 weeks to see changes in muscle integrity. So it's not going to be, an extremely quick fix overnight, but building that muscular strength is going to take time.
Just think about if you would go to the gym. I tell patients all the time, I go to the gym and I think in one day I should have muscles and be toned. It doesn't work that way. We all know that we have to actually give it. And I'll even tell patients even longer to really get to where they want to be, that 3 to 6 months, to really see those, significant, maybe to be cured. And Natalia, because she's working other groups of muscles, she may see it a little faster, but you do have to give it time and you have to follow through with those instructions.
Yep, and little habit changes every day are going to go a long way in the long run. All right, and lastly is postpartum. It is so important to get assessed by a pelvic floor PT or OT prenatal, so during pregnancy and postpartum. There are so many changes that happen to our body during those 9 months. And there's a lot we can do. Prenatal, we can do birth prep, we can do push prep, we can prepare those pelvic floor muscles to lengthen during labor. We can go over different labor positions and learning how to relax your pelvic floor and do different breathing techniques in those labor positions. It's also really important just to feel supported during this time and to understand the changes that are happening in your body, and to understand what may be normal during pregnancy and what maybe isn't normal during pregnancy. So again, all of that is super important. I will die on a hill that every pregnant and postpartum woman should go to pelvic PT. Postpartum, we look a lot at diastasis recti, so the separation of your six-pack muscles. This is very, very common during pregnancy and postpartum. Again, we want to go over that pressure management. So how are you lifting things? How are your body mechanics? How are your breathing techniques? Are we actually making things worse by kind of bulging our stomach or bulging that diastasis? Or can we breathe properly and can we engage the correct core muscles to now support that diastasis and help it close? We're going to look at any urinary, bowel, and sexual dysfunction postpartum. So again, sometimes I see women post-vaginal delivery, they may have scarring from any tearing and stitches. So we can do scar mobilizations to break up that tissue. Sometimes I see excess granulation tissue or discomfort that may require, like Kathie said previously, some topical estrogen or a vaginal moisturizer during that time, especially during breastfeeding. That can deprive the tissue of estrogen even further. And it's important, again, that we get that multidisciplinary approach. Painful intercourse or dyspareunia, again, is very common postpartum, but it's not normal, and it's important to know that there are solutions out there. And if anybody, any physician or any doctor tells you that it's normal to pee after having a baby or to leak urine when you're coughing or sneezing, it is not. And again, there are solutions out there that we can work on to help modify and to help heal those symptoms that you're having postpartum. Going back to the painful intercourse, we can talk about different lubrications that might make it a little bit easier. We can talk about doing perineal massages or stretching out that tissue before any penetration to make it more comfortable. And then there's also some vaginal moisturizers, which are going to be a little bit different than the hormonal creams that we can prescribe to help any of that dryness or irritation happening. And then we also want to help you return to your pre-birth functional level. So I've seen a lot of runners, weightlifters, swimmers, very active moms that we want to make sure we're going slowly and steadily towards their pre-baby activity levels. But it is important to know that we can get back there and we can do those things that we did before having a baby. You good, Kathie?
I think this was the last slide, right? So we have to, we kept them all in suspense because I know you've all been staying on till the end of the presentation to hear about our moisturizers and lubricants, okay? So I will give one of my favorite, one of my favorite moisturizers and two of my um, lubricants. And I'll
Mhm.
see if Natalia, I know Natalia likes one of the other ones too, so I'll let her pick one too. So my favorite moisturizer, so when we talk about moisturizing, it is like putting cream on your legs after a shower on your arms. It's moisturizing the tissue. It's not necessarily meant to be used during intimacy. However, if you do it about a
Mhm.
half an hour to an hour before, it can also be used for that lubrication. But one of the moisturizers I really like is Reverie. It's by a company called Bonafide. And it is, I never say this word right, it's mostly hyaluronic acid. So it's 100
Mhm.
times its weight in water and it just moisturizes really well. Sometimes if you use too much, it can make things too moist. I had a patient recently that she was just, she was putting all kinds of things in her vagina and she was getting yeast infections. So we want to make sure we don't over moisturize, but it really is a great product. So go ahead,
Mhm.
Natalia, you do your moisturizer.
For moisturizers, I completely second that, Reverie. And then there's also another brand called Good Clean Love.
I was
It has
thinking.
the same sorts of ingredients. It has that hyaluronic acid in it for moisture as well. So those two are definitely two that I recommend all of the time to my
All the
patients.
time. I have
Mhm.
samples. So there's another benefit to come
Mhm.
to see us. No,
Yeah.
the other thing is the lubricate, one of the lubricants I really like is called Uberlube. It's a silicone-based lubricant and it's really nice. It is, there's no odor involved and it keeps things slippery. You don't need a whole lot. I'm going to cheat and give one other one before I let Natalia talk. The other one that's often in your home, coconut oil, and it can work very well. If and you can still use the water-based lubricants first, but if they don't work or you're finding you need to reapply them, these are other alternatives.
Mhm. Yep, I like a brand called Slippery Stuff. That
Oh
is
yeah.
a water-based lubrication. Um, I also have samples that I like to give out because they're often different consistencies.
Yep.
So I'll recommend like water-based, aloe-based, or silicone-based lubrications. If you're using it with the wands and the dilators versus during any intimacy, they might be a little bit different. You might find that one texture is a little bit more comfortable or more functional for you. So I agree with all of those lubrications.
And
I personally like the slippery stuff.
what's really great about the slippery stuff, one of the reasons I do this, so many patients are postmenopausal and sometimes you have to reapply it. But the slippery stuff, what's nice about that, it is one of the ones that has the least additives. So from
Mhm.
a sensitive skin perspective, it is one of the nicer ones to use.
Yep, yeah, it's important to look at the ingredients. We want to make sure that there's no parabens and there's no glycerin in your lubrications. All of those extra ingredients can change the vaginal pH. The pH of our vaginal canal should be acidic, and if we change that, that's going to make you susceptible
Yeah.
to infections and other things that we don't want to get. So, Uberlube, Good Clean Love, Slippery Stuff, all of those are good choices. All righty. So to contact a pelvic floor PT, on the bottom right here, we have the number for central scheduling where you would call to make the initial evaluation. And then on the bottom left is our specific number for our outpatient rehab.
And the Center for Incontinence and Pelvic Health. So part of the center is myself and I have another nurse practitioner, Jamie, and then we work with both urology, urogyne, and gynecologists. We have an office in Princeton Pike in Lawrenceville, New Jersey, and an office in Newtown. All calls, though, go to our Princeton Pike office because it's just the main office. So to call us, even to reach the Newtown office, it's the 609-303-4474 number. And you don't need a referral if you have not seen, if you don't see a provider within Capital, you can still call and make an appointment to see us. You don't need a referral from someone to come in. I do refer to Natalia all the time. Every patient who walks in the door to see us, I offer that because I really do believe that it's kind of like a GYN exam. If it was up to me, every woman when they had their first GYN exam would also be sent for pelvic floor physical therapy because I really need to tell you every time I ask patients to push, whether it's related to evaluating them for prolapse, doing a bladder test, or doing evaluating bowel function, I'm going to say about 70% of people can't push. They have no idea how to push. And so if you think about that impact that happens, and you shouldn't really be pushing when you poop, but everybody does it that way. But if we talk about being able to utilize the muscles correctly, wouldn't it be great if all women got in a vow and got a few sessions when they're young, so that breathing with lifting and changing would be different. So when I win the lottery, I'm going to start a program and we're going to offer it to all our young patients.
Yeah, yeah, I agree with that. I don't think there's enough education out there for women's health, and um, pelvic floor dysfunction is very, very common, but again, it's not normal, and there's solutions
Absolutely.
out there, and you don't have to live with that incontinence. And we didn't even touch on everything that we treat in pelvic health. We do
Right.
a lot of fecal incontinence too,
Yeah.
different types of pelvic pain, urinary incontinence, urge incontinence, and there are solutions out there that can resolve those issues without necessarily having to get surgery, or those more intense medical treatments.
Right. So
And it's,
there's,
go
go
ahead.
ahead. I'm sorry.
I was going to say it's really important to talk about those issues, and um, I feel really passionate about empowering women to talk about it, because the more we can educate the community, the more we can talk about it, the more access people will have to pelvic PT and to getting those solutions.
Yeah, and that spread the word that it's not normal. I see that all the time. Patients say, "Oh," and their physicians tell them. And if you're an older woman, they say, "You're older. What do you think's supposed to happen?" And I'm like, "No, you should be able to have sex till you don't want to have sex anymore. So if you're 90 and having a lot of sex, good for you. That's how it should be if you choose to do that way. But if you don't want to have sex and you come in to see me, I won't tell your partner. I'll tell you things too." So I saw there was a question in here that I just want to address real quick, that someone had thought they had a urinary tract infection and went to urgent care, and they were told that everything came back negative. I think it's really important at that point to give us a call, come in to see us, because there are other medical things that can be going on that is causing that urgency and frequency to go to the bathroom. It's very important to rule out that there's no blood or anything like that in the urine, that can be causing the frequency and urgency, and the culture can come back negative. There are also some women have the cultures that we use today, sometimes they're not very specific. So if we really think there's a UTI going on, there is something called a PCR urine. And then there are other things. It can be a pelvic floor dysfunction issue, but we have to rule out any of those medical issues. So feel free to give our office a call and we can get you in and see you. Or call your gynecologist, your primary care physician.
Mhm. I agree. A lot of times, pelvic floor dysfunction, often if there's tone or spasticity in those pelvic floor muscles, especially around the bladder or the urethra, that can mimic UTI like symptoms, that frequency, that urgency, pain with emptying your bladder, and doing some of those manual releases and stretches and breathing and different techniques to learn how to properly empty on the toilet can be extremely helpful.
And I completely agree. And realize too, there are other foods and fluids that can really irritate your bladder. So if you had one of these episodes and you had some alcohol or drinking more caffeine or a lot of spicy foods, acidic foods, those things can cause a lot of those symptoms also. So just kind of keep that in mind and look at what you were doing. Make sure you've increased your water intake, and not carbonated water, just good old boring
Plain
water.
water. Yeah,
Good.
and dehydration can
And
also be a bladder irritant. So if you're not drinking and your pee is very yellow or amber, that in it of itself can be a bladder irritant. So we typically say about half your body weight in ounces of water per day. I usually say just take a look at your pee before you flush the toilet. If it's like a pale yellow or a clear, you're in that good range. If not, try to increase that plain water.
I did want to interject something. If you do see us, because Natalia and I do a lot of the same things, I have every patient do a bladder record. So if you see one of us and you go see the other one, we won't make you do it twice. Just bring your bladder record with you.
Yes. I see another question for what are your hours for pelvic PT? So I work Monday through Thursday. I'm here 7 a.m. till 6 p.m. So we kind of cover morning and evening. You do need a script to come see us at the hospital. So as long as you have that script, you can just call central scheduling and then you'll be able to get on our schedule. We do have two other therapists. I think one of them sees patients on Fridays as well. All right. Another question, a 60-year-old woman has a need to pee when she stands, now 5 to 7 times per day. Started all of a sudden, she hasn't had any leakage, pain, or accidents, but when she goes to the bathroom, she does pee each time. So normal frequency is going to be between 5 to 8 times per day, or about 2 to 5 hours between each void. Um, we would want to assess this person, but if they are standing up and has this sudden urge, it could be any weakness in the pelvic floor or not being aware of those urges. This is where those voiding schedule might come in handy, because if we're over holding it, we can get something called overflow incontinence, where we're kind of sitting, doing our work, we lose track of time, and then all of a sudden that urge comes on super quickly. So we would want to look at, what is that person drinking? Are they having any bladder irritants? What is their integrity of their pelvic floor? Any behavioral changes?
And it is important to do that baseline assessment too, to make
Yeah.
sure that there's no blood in the urine, there's no infection, to rule that out, to make sure that, one of the issues too, when we talk about all of a sudden, it sounds like it is more of a pelvic muscle because it's with position change. So it can be a urethral issue, but if you haven't had this problem in the past, again, we want to rule out things such as diabetes, sugars being elevated can cause all those types of changes in how your bladder is going to work. So just coming in for an evaluation is always the best thing.
Yeah. Yeah. I always say it's the best information we're going to get is when we can do that full, thorough evaluation, when we can look at those diaries, we can look at the trends and the patterns and what you're drinking, what you're eating, and then how your pelvic floor is functioning itself. Is there tone? Is there weakness? Then what's the integrity of the tissue itself? If we're talking about a 60-year-old woman, maybe she needs that moisturizer or that topical estrogen to help with that urethral stability.
Absolutely. And I, again, it's really getting that baseline assessment that's really important, and then educating you based on what we find. I see another question. Can you get a script from your OB? Yes. If you're not seeing us at the Center for Incontinence and Pelvic Health and you've had a baby recently, certainly, just especially if you have an OB from Capital Health, they're very good at referring over to pelvic floor physical therapy. Some of them will refer to the center first. We'll get you started and then go to physical therapy, but you don't need to do that. You can go right there.
And you can get a script from any physician, your primary, urologist, urogynecologist, GI docs, your OB. And if you feel like you need pelvic floor PT, you can ask your physician for it too. And you are always entitled to a second or third opinion if you feel like you're getting that pushback. Pelvic PT is super important. So, finding that provider, that group of providers that's going to support you is really important.
And then somebody said they came in late. What's a bladder record? So I call it Weight Watchers for your bladder. The idea is we're going to have you keep track of what you drink and how much, and when you go to the bathroom and how much you go. Because people come in and it is normal, like Natalia said, to pee about 6 or 7 times a day to pass your urine. But some people will come in and not be drinking very much and still going 6 times a day, or other women who are coming in and drinking 120 ounces and going 5 times a day, which could be the problem. Remember too that our bladders are controlled by nerves and the sensation, and you should really, and we didn't even talk about this, but you should be getting different sensations. And sometimes I joke around, you could have nurse's bladder. We never listen to our bladder. And so we wait till that last minute and there's that sense of urgency. So the bladder record lets us know how much is your bladder holding, how much fluid are you drinking, when are you leaking, are you having any pain? So it's a great tool to give us a ton of information without being invasive at all.
I'll also look at urgency. So how strong was that urge that told you had to go to the bathroom? And I'll grade it from a 1 through a 3. A 1 being I went to the bathroom just because I was leaving the house. I didn't actually have an urge to go. I was just going just in case. 2 would be a pretty normal urge. And then 3 would be I waited until the last possible second. If I didn't go right then and there, I may have had an accident. And then I also look at any leakage and the activities that you're doing when the leakage happens. So this can really help us understand, are you having stress incontinence? Are you leaking when you're laughing, coughing, sneezing, jumping? Or are you maybe having urge incontinence where you get an urge to go to the bathroom and then you see the toilet and you're leaking on the way to the bathroom, or you're putting a key in the door and all of a sudden that urge increases tenfold and you feel like you can't hold it anymore. Or maybe it's a combination of both of those things.
And mine has the same thing. I was just keeping it low, but we do the same thing. When do you leak? Because a lot of people do a ton of preventative toileting. You know, you go because COVID was awful for that. You're home, everybody's home, the bathroom's right there. I'm bored at work. Let me get up. Let me go to the bathroom. And so again, like Natalia talked about, some of it is bladder retraining, kind of changing how we go to the bathroom.
And then another thing too is, are you waking up at night to use the bathroom? So depending on age, it may be normal to go once at night, but if we're going 3, 4, 5 times at night, there are other behavioral things that we can look at throughout your day to decrease that urgency and that frequency at night as well.
Absolutely.
I'd like to remind people that if you have questions, you can take yourself off mute and ask them as well, or put them in the chat box if there are any remaining questions. And it doesn't appear that there are. So I wanted to just take a moment to thank Natalia and Kathie for an absolutely outstanding and very, very informative presentation this evening. I have
we have
raised
one question.
Yeah, hi, this is Renee. I had a question about the pessary. I was reading that it can help correct prolapse. Is that true?
So it doesn't correct it, but if you take the pessary out, things will go back to the way they were previously. But it supports that tissue to hold everything in place or hold it up into the vaginal canal.
Okay.
I kind of compare it to an orthotic device, like something that you would put in your shoe to support your foot. It can kind of be like an orthotic device for your vaginal area, and they are.
I haven't thought of it that way.
They're really great devices, and for somebody that maybe has a more progressed prolapse and doesn't want to do surgery, we can try all these pessaries. And like Kathie was saying before, it's not a one size fits all. There's so many different types of pessaries out there, but they can be a really great thing to supplement those symptoms you may be having while we're retraining everything else in pelvic PT.
So just to let all of you know, when God was giving out talents, my talent was pessaries.
Well, then I have one last question for you about the pessary. How long is it useful? I mean, can you use it for 5 years, 10 years, or is it just depends on the person?
So what I tell people is pessaries are a temporary device. And so pessaries can last for, I have patients that have pessaries for 5, 10 years, not the same pessary. We usually give you a new one every 6 months to a year. But the problem is what we're finding in studies across the United States is that pessaries will usually work for about 10 years and then they seem to not work anymore, even if you change the type of pessary. And so you just want to keep that in mind when you're trying a pessary, that it really is supposed to be a temporary device. I always felt very bad. Many women, when I was in the GYN offices, we were putting pessaries in all the time to prevent surgery, doing exercises, doing those things, but utilizing a pessary. And then 10 years later, they were coming in because I was at the same office for that long. And then all of a sudden they stopped working. So you just want to keep that in mind. It is a wonderful option. You can take it in and out yourself. Some women who can't take it in and out themselves come into the office. It can be from every month to every 6 months, depending on your tissue, how your body responds to the pessary, and what type of pessary it is.
Thanks.
You're welcome.